we'll be all good. All right. So welcome in, everyone. Today, we'll be talking about benzodiazepines, which is a fantastic group of drugs with a lot of different uses, very interesting chemistry, and extremely interesting uses and indications in the medical world. Just a little overview of today. So we'll be going through the history, the development, the chemistry, and the usage of benzodiazepines, as well as having kind of a discussion about all of them in general. If you have any questions during the presentation, feel free to put them in the chat, unmute yourself, whatever you prefer. Just know that if you do talk out loud, you might be picked up in the recording, so just bear that in mind. Also on the SAR MedChem subreddit, there's going to be a dedicated forum discussion. So if you have longer questions, or if after the video you want to go there and ask a question, that's the perfect place to do it. So without further ado, we'll jump in and we'll talk about benzodiazepines. Should be a lot of fun. Likewise, just to kind of start off here, as a disclaimer, this is just a general conversation about benzodiazepines. In no way, shape, or form is any of the information discussed here medical advice for you specifically. This is just talking about the chemistry and the uses. Make sure to consult your doctor before starting, or changing any medication. Likewise as well, don't attempt to synthesize any of the drugs that we talk about today. These need to be done in a controlled environment and should not be performed without proper training. And then likewise too, we don't condone the use of prescription medication for non-legitimate purposes. So without further ado, I will pass it right over to Brandon to talk about history and development of benzodiazepines.
Hello, my name's Brandon. I am a PhD student in medicinal chemistry, and so my background is very much the chemistry, the synthesis, the beginnings of how drugs are made, rather than the end use, the clinical side and things like that. So benzodiazepines, as I'm sure many of us are familiar with, are used primarily as sedatives, and there's been a few different classes of sedatives in history. And if we look into almost prehistory, our first sedative is good old alcohol. Many civilizations going back to the Romans, to the ancient Greeks, used alcohol both recreationally and into some degree medicinally. And it works kind of, but it's not an ideal drug. It's far from an ideal drug. Then in 1903, we had the discovery of a drug called Barbital. So this is when we had the first sort of real marketed drug, the real marketed sedative. So if we have a look at the next slide, we will see that we've got a nice yieldy ad for a soothing syrup, which contains Barbital. So Barbital is the structure we can see on the left. And on the right, we have what we would call the sort of common backbone, or as we'd later learn, a pharmacophore. So it's a common structure to all of these drugs. And we can see at the bottom, there's R1 and R2. These denotes parts of the molecule we can change, and well, it will change how the drug behaves in the body, so maybe how long the drug lasts or how potent the drug is. Most substances with that structure will have more or less the same effects. They'll all be sedatives. So how were these discovered? If we have a look at a little bit of the chemistry, we have two synthetic schemes. The top one is specifically for Barbital, and we start with malonic acid, which is the leftmost structure on the top scheme, and you can form what we call the dimethyl esters. So we form dimethyl malonate, and that's quite an easy reaction. anyone who's taken A-level chemistry, high school chemistry, has probably come across this type of esterification reaction. We can then alkylate that central carbon between the two carbonyl groups. In this case, we alkylate it twice with ethyl bromide. So we put on two ethyl groups, there's two carbon atoms. And then we do a condensation reaction with urea, which is that molecule above the last arrow, and we form our target drug, Barbital. Now, medicinal chemists will then want to explore different, very similar drugs. So with this scheme, you can alter the alkyl bromide used, so the reagent underneath the middle arrow, to anything you can get your hands on, and you'll make all different barbital derivatives. And this is exactly what we've done. We have a number of barbiturate drugs that have this general structure but are altered by the R group down the bottom. So why don't we still use barbital and other barbiturates? They're bad drugs, and when a medicinal chemist says something is a bad drug, what we generally mean, well, one of the reasons we can say that is that it has a bad therapeutic window or therapeutic index. And so if you have a dose of a drug, if you have a very, very low dose, nothing's going to happen. If you increase it, you're going to get the desired effects, the therapeutic effect. If you take a bit too much, you get toxic effects. So this is what we deem a side effect. And if you take way too much, you're going to die. So a good drug for a medicinal chemist is one where the therapeutic effects or the therapeutic window, the dosages are as wide as possible. So a bad drug has a very narrow therapeutic window. An okay drug has a decently wide one. The best drugs have very wide ones. So it doesn't matter if you accidentally take 2 pills or take a pill too early, you're still going to be within that therapeutic window and you're not going to go up into toxic or die from it. So barbiturates were very much in the bad drug window. It's very easy to overdose on them. So in 1960, we found a drug that we thought might solve this. So our solution were the drugs that this talk is mainly about, the barbiturates. So the main useful thing here is that they're, so in 1955, we had our first one, chlordiazepoxide, which is better known as Librium, as its brand name. And it took off quite well, simply because if you accidentally took slightly too much or you took your second dose earlier, there's a far, far, far lower chance that you would just die, which is quite desirable in a drug. So if we was to draw a therapeutic window against our dose of drug, we can see on the right, the chlordiazepoxide has a much wider therapeutic effect. It's not massively wide, but it's far better. So on the right, we can see that the therapeutic dose versus the lowest dose where you're going to get toxicity. If you use to divide one by the other, you get a number for the therapeutic index. And for phenobarbital, a commonly used barbiturate, the index was 53, whereas for diazepam, a very commonly used benzodiazepine, is 224. So it's roughly 4 times safer. So how do these drugs work? I'm going to hand over to Gabe for this, since he's a pharmacist and much more knowledgeable on the pharmacology.
Perfect. Yeah, thank you. So my name is Gabe. I'm a PY4 pharmacy student based out of Boston, Massachusetts. And my passion really comes from looking at where chemistry and medicine really come together, which is, as the kind of blogger on SAR MedChem, really where I wanted to be able to talk about and really expose people to this information. So my passion comes from the pharmacology, which is the application of chemicals in the body. So when we look at benzodiazepines, really what we're looking at is 2 big indications or uses of them as drugs. So the FDA, the Food and Drug Administration, is the American organization that's responsible for dictating what a drug can be used for. Although many times drugs are used what are called off-label. And while that's not necessarily a bad thing, it's just that those drugs weren't necessarily approved for those specific indications. So when we look at benzodiazepines, the FDA has approved them for uses like anxiety and insomnia. And you've probably encountered a lot of benzodiazepines in these two different ways. Often people are given lorazepam for their anxiety, or maybe as a sleep aid when they're trying to go to bed. Likewise, in a non-psychiatric way, we use benzodiazepines as pre-medication for anesthesia, not only to calm the patient, they might be anxious for whatever procedure is going to be happening, but also to sedate the patient and make them go to sleep. One of the uses that I think most people don't really realize is status epilepticus, which is an emergency situation of seizures. And so this is something that we'll talk about a little bit later, where we'll focus specifically on it. And then over on the right-hand side, we can see some other non-FDA approved off-label uses, things like agitation and behavioral syndrome in older patients with dementia. Also can be used for chemotherapy, nausea and vomiting, burn pain, and then probably one of the biggest uses off-label is alcohol withdrawal syndrome, in tampering down the seizures that can come from alcohol withdrawal. Diving into talking about the receptor specifically, Brandon, do you want to talk a little bit about these two chemicals on screen?
Yeah, so before we talk about the chemicals, there's an interesting colourful picture, and this is where the benzodiazepine and barbiturate drugs actually act in the body. It's called the Gaba Receptor. So these are found, if I'm not mistaken, in most nerve cells, particularly in the central nervous system. And the molecule within your body that actually your body makes to make this channel open up, because what we're looking at in this picture is we're looking down a hole. So right in the center, there's barely anything that stops things, and we have chloride ions that travel down that. And that's what causes this effect of sedation. And to open up this channel, so it's almost like a gate between the inside and outside of our nerve cells, we have a chemical called GABA, which stands for gamma aminobutyric acid. So there's an amino group on the right hand side and a carboxylic acid on the left. And when our body needs to essentially open up this channel, it releases some GABA and it binds to it. Very similar is GHB, which is used for some nefarious purposes, but it's a very similar looking molecule. And also very similar, if you used to literally cut that molecule in half, would be ethanol. So alcohol that we drink, which is why alcohol causes us to be sedated. So we have one receptor, one part of this ion channel where these molecules will bind, but the benzodiazepines and barbiturates actually bind somewhere slightly different. So here's a slightly more complicated, well, simplified in terms of the colors, but more detailed picture of our ion channel, our Gaba ion channel. And on the right, we can see that there's a site for GABA, well, two sites for GABA, and that's where also alcohol binds. But on the right, between the green and the purple, there's the BZD site, or the benzodiazepine sites, and that's where our barbiturates and our benzodiazepines bind. So what happens when they bind is it actually makes the affinity for GABA and alcohol higher. So it essentially potentiates or makes the effects of alcohol or GABA more potent. So for a bit more detail, I'll hand over to Gabe.
When we talk about benzodiazepines specifically, one of the things that we should always keep in mind is how does the drug get in the body and what does it do from there? So as a pharmacist, and also medicinal chemists in a lot of ways, we always look at ADME. And I like this picture on the left because it also talks about an added part of the journey of a drug of liberation. So if you were to take a pill, what happens is you swallow it and it enters into the stomach and the intestines. So we can see on this diagram on the right, you administer your drug, it is absorbed into the bloodstream via the small intestines. And then from there, it's distributed all across the body. So as a pharmacist, we really care a lot about what happens to a drug and every single step of this. How does it get released from that pill or that capsule? How does it get absorbed into the bloodstream? Is it full absorption? Is it a partial absorption? And then also that distribution. What was really challenging for me as a student was understanding that a drug goes everywhere in the body. And understanding that when we have something ingested, not only is it going to the place that we want it, but it's also being sent everywhere else. And then over time, it's metabolized through the liver and deactivated. Eventually, this deactivated drug will then be excreted through usually the kidneys, sometimes also through the feces, where it will eventually leave the body. When we think about drugs, obviously we can think about pills and capsules. Those are probably the most common types of administration, the dosage forms that we find. But specifically with benzodiazepines, we actually see a couple of interesting applications. One of them that people might not be aware of is the Diazepam Rectal Gel. And this is administered through the anus into the lower colon, specifically to aid in a child having a seizure. So the reason why we would do this is because if someone is seizing and they're on the floor and they're going through their tonic-clonic motions, they're not able to swallow a pill. So having an alternative route like the rectal gel or even this new Valtoco nasal spray is a fantastic alternative administration point. So instead of it being absorbed in the small intestine, we're seeing it absorbed directly through the colon or directly through the nasal passage, which is fantastic. Once a drug enters into the body, this is really where we start to talk about all the different properties of the drug. And our medicinal chemists are obsessed, really, with all the different kinds of properties different kinds of drugs can have.
We are indeed. And so, as well as looking at various routes that we can get a drug into the body, so as Gabe said, most common one is a pill, and that's what, as medicinal chemists, we aim for, because at the end of the day, if you want a medicine, you just want to take a pill and that's it. You don't want to inject it because not everyone is fond of needles. Rectal administration isn't going to be the most popular idea either. So generally we want it packaged up into a nice pill. But once it's in the body does all sorts of things to drugs. And this is where benzodiazepines are a really interesting study, because here we've got the pharmacokinetic profiles, so basically what the body does to drug, of a number of benzodiazepines. And on the top right, highlighted is chlordiazepoxide or Librium. And that was the first marketed benzodiazepine. And on the very right-hand side, we have the active metabolites. So although chlordiazepoxide is a benzodiazepine, it's metabolized into other benzodiazepines. And because metabolism is very much individually motivated, trying to think of the right words. Basically, it varies considerably from person to person. If I took a pill of chlordiazepoxide and you took a pill of chlordiazepoxide, how fast it's metabolized and how fast the active metabolites, the other benzos that it makes, is very variable. So from a medicinal chemistry standpoint, this is quite undesirable. And from a clinical standpoint, if the pill you give, you can't actually guarantee how long it's going to last, that's not ideal. So it actually gets metabolized into a very common benzodiazepine called Valium or Diazepam. So this is very commonly clinically used, as I understand, but we suffer from the same problem. It gets metabolized into drugs, well, compounds that are themselves active. So medicinal chemist then looks at these active metabolites, and we come across oxazepam. Well, we named it oxazepam. And this is a benzodiazepine that none of the metabolites are actually active. So it's far easier to predict how long it's going to last in the body, how long its effects are going to last. And that's quite important with a drug, because especially drugs where the side effects are sedation, well, the effects are sedation, which, you know, you want to be able to predict when you're going to be able to drive again or operate heavy machinery. It's quite important. This is a nice little idea of how medicinal chemists like to look at drugs. We try and find these little hidden things where, oh, we can make it so that it doesn't turn into anything that's going to interfere with what the drug does. So a nicer demonstration that is on the next slide. So as I said, we have chlorodiazed epoxides, that's on the left, that's Librium, which initially was marketed for anxiety and hepatic metabolism. So in other words, our liver turns it into diazepam or nordiazepam, a mixture of drugs. This then also gets metabolized into oxazepam, but then that gets metabolized into non-active things and is eventually excreted in the urine. So if you want a drug that's predictable, you want it to be something like oxazepam, where it's not going to turn into things that also do the same thing, but might be stronger or weaker or last longer or last shorter, and predicting what the drug's going to do becomes a headache. So we're going to look into a bit of the synthesis of these drugs. So I've picked the drug nitrazepam, otherwise known as Mogadon, because this was actually something I had to make in my third year as an undergraduate. And it's quite a nice synthesis to look at from a chemistry standpoint, because we've got one of the most common bond formations we see in medicinal chemistry, which is an amide coupling. We also see the importance of purification because we use a highly toxic reagent. And then we also see that same importance of purification with an annoying byproduct. So our first reaction on the top, so from the top left to the top right, we use a compound called bromoacetyl bromide, which is above the arrow, and our starting material has a very long name, which we just call it A. Chemists genuinely do this. The names get too long and too cumbersome, so we just call things A, B, and C. So we have our first reaction. This is forming an amide bond. So at the top of the left-hand molecule, we see an NH2 group. This is an amine. And on the right, we can see we've made it into what we call an amide. So it has an N bonded to a carbon, which is directly bonded with a double bond to an oxygen. So this NC double bond O is an amide, and it's one of the most common functional groups or bonds we see in a lot of drugs. So this is quite a nice reaction and works very well. However, bromoacetyl bromide is rather toxic. It's a very good lacrimator, so it causes you to cry. In other words, it's tear gas. So we want to make sure we get rid of that. And it's quite easy to do in this case because it's very volatile. You can boil it off, whereas our products has a very, very high boiling point indeed. So it's rather easy to remove. Our next reaction is even more concerning in terms of toxicity of reagents. So our NaN3 is sodium azide. Now this has a toxicity that's comparable to cyanide. In fact, it acts on the same molecular target as cyanide, the cytochrome enzymes. Unlike cyanide, it doesn't have an antidote. So when we work with this, we've got to be very, 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 very careful indeed. If you accidentally dose yourself with cyanide, doctors can save you. If you dose yourself with azide, there's nothing they can do. And obviously you don't want any of this left in your drug. So this is why medicinal chemists spend lots and lots of time working out purification methods, because you want to make sure what you have is that you know exactly what's in there. And if it's not pure, you know exactly what the byproducts are and that they're not toxic. So we form this azide in the bottom right-hand corner, and we do a nice fancy reaction called a Staudinger ligation. Now, I'm not going to go through this because if I do, I'd be talking for a long time. However, long story short, we form our overall benzodiazepine molecule. Now, just like the Barbital, we can actually change things up a little bit. So if we have a look at the next slides, it's very much the same, but more generalized. So with our starting material, we have 2 aromatic rings, the 2 hexagons. We can change what's actually attached to those, and it will clue into what we end up with. Similarly, our bromoacetyl bromides, we can attach different functional groups to, and they will carry on through to the final molecule as well. So this is why we like reliable reactions as chemists as well, because if it's reliable, we can usually change things and end up with very similar products and explore their pharmacology as well. And why would we want to do that? So if we have a look at the next slides, we go back to a familiar table. However, something else is highlighted, the half-life. So drugs will last different lengths of time in your body, and their effects will last different lengths of time. And from a clinical standpoint, this can be quite useful, especially if you have drugs that more or less do the same thing. So in this case, they're all sedatives. However, diazepam will last a lot longer than, say, midazolam. So the half-life of diazepam is 20 to 80 hours, whereas for midazolam, it's under 2 hours. So if you want someone to be sedated for just a very short period of time, I imagine a doctor would use midazolam. Whereas if they want you to be sedated for a much longer period of time, they'd probably call for diazepam. I will hand over to Gabe either to expand on this or to carry on.
Yeah, so to go back to a figure that we looked at earlier too, that when we look at the effect of benzodiazepines specifically on the GABA receptor, what we're really looking at is, from a clinical standpoint, the effect of having more chlorine. So Brandon had talked about how benzodiazepines bind in similar ways to GABA. And what we really care about as pharmacists is how they potentiate or increase the amount of chlorine that is piped through this pore. Chloride is a ion that is throughout our body, and it's can be thought of as an inhibitory ion, where it decreases the excitability of our neurons. And what this means is that we're getting lots of decreased central nervous system activity. So what we're looking at is things like drowsiness and sedation. This could even culminate into enterograde amnesia. So we're unable to form new memories, which is great for when we're going through surgery. We do not want a patient to remember their body being cut open, as well as that calming and anxiolytic effect, or the anti-anxiety that we're looking for from benzodiazepines. Likewise, because benzos interact in the same sort of location as other CNS depressants like alcohol or GHB, we start to see that they can have multiple different interactions. Likewise, other drugs that depress the nervous system, like opiates or other sedatives, are going to increase our overall toxicities. And so one of the things we think about as pharmacists is looking at the on-target versus the off-target effects. So we talked about earlier that when a drug is introduced into the body, we really care about where is it going. And we have no way of controlling which tissue it will enter into. We have no way of telling a drug, oh, make sure you don't go to the liver or make sure you don't go into the lung. And benzodiazepines act the same way. So here I've listed a few different adverse effects or side effects of benzodiazepines. And you can look at these and you can start to see, okay, what's an effect of it attacking, or not attacking, what's an effect of it activating the GABA receptor, and what's an effect of it activating something else that's going on in the body? And so what we see is that things like when it affects the cortical regions, like the frontal cortex and the cerebral cortex, which is our decision-making and thought processing part of our brain, we're seeing things like cognitive impairment, and we're seeing things like our inability to, make complex decisions, which makes sense. If someone is more tired, they're unable to really have a complex thought. Likewise, the effect on the hippocampus right here in the center of the brain is involved in memory formation and emotional control. So we can see that with benzodiazepine use that we're looking at things like emotional blunting or that anterograde amnesia that we had talked about before. The amygdala just above the hippocampus is involved with pleasure and pain in the reward system. So we're looking at things like dependence and addiction, as well as that kind of feedback mechanism that makes someone potentially want to misuse benzodiazepines. The cerebellum at the back of the brain is responsible for things like balance and coordination. And so we're seeing that someone using a benzodiazepine may become dizzy, or they might be walking with a gait disturbance. Perhaps they're having a visuospatial impairment, meaning that they're not sure the distance between something. Often this is them, missing putting something on a table, and maybe a glass falls off. And then finally, the reticular formation is about autonomic processes. So these are things like arousal and breathing and swallowing. And we can see that the effect of the benzodiazepine is that it can decrease all these autonomic processes, which can eventually be very dangerous, especially in overdose. If someone is decreasing their breathing too much, or if they're not swallowing their saliva, they could potentially choke on it. So what we've talked about so far is all the on-target effects. So these are side effects because benzodiazepines are doing what they're supposed to be doing. They're activating the GABA receptor and decreasing the CNS. What we can talk about now is the off-target, which is where the drug has gone to other areas in the body and caused issues. So one of the big ones we see is dry mouth, or that the body produces less saliva, making it very irritating for someone to swallow or chew their food. Likewise, liver failure and toxicity can be common with benzodiazepines, especially when used with other drugs. We start to see the liver being overwhelmed. Nausea and diarrhea from the irritation of the gastrointestinal tract. And then finally, a very serious autoimmune reaction called Stevens-Johnson syndrome, where someone can have an allergic reaction to benzodiazepines and their skin literally falls off. And it's a medical emergency. And sometimes it doesn't present for 5, 6, 7 days after they were administered the drug. And it might just be coming out of nowhere. So what we see is that understanding the chemistry of benzodiazepines is extremely important for seeing where it's going to go and what it can do. Now, with all that in mind, talking about the different half-lives that Brandon was talking about earlier, we can see different indications about what they are used for. So our shortest acting drugs in the top left are midazolam, triazolam, alprazolam, and oxazepam. These are going to be the quickest onset and are going to be starting very quickly and ending very quickly. So we can see like sedation and anesthesia. We want someone to fall asleep very quickly. Maybe if someone is having issues falling asleep with their insomnia, these are great drugs for that. Likewise, looking at intermediate acting, so between 12 and 24 hours, we're seeing more so that anxiety, we need more maintenance during the day or during our sleep cycle rather than something quickly that we need to get over. So lorazepam is probably the quintessential intermediate acting where it can be used for many, many, many different uses. Here I've just listed a few. And then our longest acting ones that act longer than 24 hours, especially diazepam and clonazepam, we're going to be using for almost daily use and for maintenance of anti-anxiety, epilepsy potentially, as well as our more our longer surgeries that we want to make sure that the person isn't awaking for. Kind of an interesting anecdote here for diazepam is the use in the B52 shot, where if a patient comes in and they are agitated, we actually administer a intramuscular injection of diazepam, Benadryl, and an anticholinergic in order to calm that patient down very, very quickly. And so that way we can perform whatever procedure we need to. So lots and lots of different uses for a very dynamic group of drugs. The next section that we're going to jump into is just talking about the three main indications for benzodiazepines. But before we begin, does anybody have any questions about benzos so far? Great, perfect. All right. So without further ado, let's jump into a very, very interesting part of medicine, anxiety and sleep. So when we look at anxiety specifically, what we can talk about is, in general, what is anxiety? And anxiety specifically isn't necessarily a bad thing. It's something we've developed evolutionarily. It keeps us safe. It keeps us apprehensive about new situations. So from an evolution standpoint, having anxiety isn't necessarily a bad thing. What we talk about when it becomes bad is when it is disruptive to someone's daily activities or is excessive worry. And what we can see here is, as it's defined in the DSM-5, is that excessive worry or apprehensive expectation occurring more days than not. And it's really that interruption in someone's life that we start to treat them for their anxiety. And we notice certain things that benzodiazepines actually work really, really well for. Irritability and sleep disturbance, being easily fatigued, restlessness. So these are all things associated with, maybe not being able to fall asleep or constantly worrying and being ruminating on certain thoughts. And when we look at where anxiety comes from, we can see multiple different places. And truthfully, we're not really sure where anxiety specifically comes from. This is probably a situation where it's more of an and situation than an or situation. And what we can see is that it could be neurobiological, like a disruption in serotonin or even GABA. So something more similar to what we think of depression. Could be related to substance abuse or misuse. Even a prescribed medication can sometimes cause anxiety as well. So it doesn't necessarily need to be a bad thing. It can be using it correctly. Environmental factors or developmental, like trauma or PTSD. And then finally, secondary to other medical conditions like endocrine diseases or cardiovascular, or even just worrying about the outcome and prognosis, then this can be, quite nerve-wracking for a lot of people. When we look at the anxiety disorders, a lot of people start to think that benzodiazepines are first line in pretty much every kind of anxiety disorder. And that's an oversimplification. So here I've listed some of the more common ones. And specifically, I want to focus on the first three here about generalized anxiety, panic disorder, and social anxiety disorder. So generalized anxiety is when someone has anxiety throughout most of the day and for more days than not. So they're generally worried about multiple things during the day. They may not be able to focus on one specific reason, but it's interrupting their ability to have a meaningful daily life because they're so worried about something going on. One of the things that we used to do a lot was prescribe benzodiazepines, but now with the development of SSRIs like sertraline and citalopram, we're starting to use those more first line along with cognitive behavioral therapy because that ends up being a more holistic environment for an anxious person rather than just sedating them like with a benzodiazepine. So generally for GAD, we're using benzodiazepines as second line. This is not usually a first line option. And the reason is because someone's having anxiety throughout the day. They don't need to be tired. They need to understand what the issue is and work through it. We can't just sleep our life away. Once we go into panic disorder, we're looking at it a little bit different. Panic disorder is where we have panic attacks, which is a physiological process where someone is so overwhelmed with anxiety that they physically start to hyperventilate and they are unable to process what's going on. And in that moment, it can feel like they're dying. And for a lot of people who have a panic attack, sometimes they think that they're having a heart attack or they're undergoing some sort of major physical damage, when in reality, it's mostly an anxiety that's culminating into this major panic attack. So with panic disorder, we need to stop the panic attack as quickly as possible. And this isn't something that someone's having panic attacks throughout the day. You know, this isn't that they're having it for an hour or 2 hours at a time. They're maybe having a panic attack that's going to last 20 minutes, maybe 15 minutes even. And that would be on the upper side of a panic attack. So what we need to do is we need to stop the panic attack as quickly as possible. So what we're going to use is a short-acting benzodiazepine. So unlike with GAD, we want to administer a benzodiazepine first because it will calm that person down quickly and sedate them so that way they can be removed from the panic attack quickly. For chronic panic disorder, we want to follow it up with our SSRIs and our SNRIs, as well as cognitive behavioral therapy, so someone can have not only the acute fix of their panic attack, but also we're looking at it from a chronic standpoint. Finally, when we're looking at social anxiety disorder, we're looking at anxiety due to participating in social situations where someone may believe they're being persecuted or the social situations are stressful. And again, we're looking at that benzodiazepines are taking a secondary line here because we can't have someone sedated all day long just so that way they can get through the day. We need to work with them with an SSRI and cognitive behavioral therapy so that way they can learn how to adapt in the social environment. And then if they need it, a benzodiazepine, maybe they're giving a presentation or maybe they're performing and they just need something to calm down with. And so really these are our three biggest anxiety disorders that we see. And you can see that benzos take a much different role depending on what the etiology of the disorder is. Once we go on to something like insomnia, insomnia used to be almost completely directed by benzodiazepines. Remember that one of the main functions of them is to sedate a patient and make them tired. So of course we would want to use a benzodiazepine because it's going to accomplish that goal. What happens now is that people were given benzodiazepines so liberally that we started to see addiction and dependence even if someone wasn't necessarily abusing the medication. And while I was talking with Brandon earlier, the United Kingdom actually has a big issue with benzodiazepines, whereas in the United States, for us, it's more of the opiates that are causing a more addictive environment. What ended up happening is that back in the late 80s, early 90s, the development of a new type of drug called the Z drugs, as well as orexin antagonists, made benzodiazepines really obsolete in the treatment of insomnia. And so what we'll find is that we're going to use those Z drugs first because we have less risk of dependence and withdrawal, less risk of abuse, and less risk of cognitive dulling, especially in our older patients. So don't be surprised that if you are talking to someone and they're being treated for insomnia, that they might never even come into contact with a benzodiazepine because we have much better and safer options. Likewise, kind of a new development in the last 10 or 15 years is really focusing on the non-pharmacological side of insomnia. So really helping someone understand what sleeping is like, how to develop better sleep routines, and not even necessarily needing a drug, and putting your phone down, not watching TV, and just relaxation therapy rather than using a drug as well. Our last section that we're going to talk about is probably one of the least known parts of medicine, or status epilepticus. And so what status epilepticus is a emergency situation where someone is having a seizure. And this is a seizure that is constantly potentiating and going on, and it just won't stop. And seizures alone can be very, very scary. They can be very dangerous, and they can potentially kill someone because of the disruption in the brain, as well as if it's happening while they're driving or operating, or maybe they're riding a bike. That person can fall over, hit their head, and then have a brain bleed. So seizures in general are very, very scary, and there's something that we're very acutely aware of, and status epilepticus is the worst of it. So in status epilepticus, what's happening is that we have a seizure that just won't stop. And so what we focus on is the trying to terminate that seizure as quickly and as completely as possible. So on the right-hand side, I think this is a great diagram to read through later. The slides will be posted on the subreddit as well, where you can read through how status epilepticus is treated and how we go through these different phases of saying, okay, we need to do this. It's not working, we need to do this. And we're really trying to pump someone full of drug as quickly as possible, so that way we can stop that seizure, because that patient could potentially die very quickly. And we need to have our biggest action as quickly as possible. So when we think about status epilepticus and treating it, really what we focus on is using a benzodiazepine that has a quick onset and a long duration of action. And so if you want to take a moment real quick and just in your head, or potentially typing in the chat too, which drug you think accomplishes this goal of quickest onset and longest duration of action the best, and what you would choose from what's selected. So I'll give people a moment to kind of consider. So when we look at status epilepticus, what a lot of people, when they were writing these the guidelines for it, initially went to diazepam, or this drug here. And what they looked at was this onset of action. And you can see that if someone's having a seizure, we're not giving them a pill, right? We're going to pump, we're going to slam an IV into them as quickly as possible. And so having a drug that acts within 1 minute could be the difference between life and death. And so when we look at the half-life here of it potentially surviving in the body for up to 50 hours, that's a huge benefit. But when we look at the guidelines, we actually see that midazolam, which has a shorter half-life and it takes longer to act, is the preferred agent. And in the United States, we use a lot of lorazepam as our drug. And the question is, why? Why would midazolam and lorazepam be used even though they could potentially take up to 5 minutes in order to start terminating the seizure? And the reason is because of the duration of action, is that we don't care how long it happens, how long it takes for it to act. Shorter is always better, but we want to make sure that the drug is acting as long as possible. Because just because we stop someone from having that seizure doesn't mean it's going to stop completely. It could come back in 10 minutes. It could come back again in an hour. It could come back while the nurses are changing shift and nobody's watching the patient. So midazolam and lorazepam are preferred agents here because even though they take a longer amount of time to start working, they act longer than our diazepam would. So we'll primarily be choosing those two agents specifically for what we're doing. Any questions about the three uses that we've talked about so far? Ooh. How come diazepam is that much more lipophilic? I'd actually have to pass this over to Brandon, if you know off the top of your head.
Yeah, so if you were to look at the structures of those drugs, off the top of my head, lorazepam, midazolam tend to have more electronegative elements in, so things like nitrogen and oxygen. These allow the molecule to hydrogen bonds to, say, water, and this attraction to water lowers the lipophilicity. Yeah, there we go. This was a complete guess, but there we go. The less electronegative elements means that it's less lipophilic in a nutshell. So, is it the sole reason? Like with a lot of chemistry, there's multiple facets. Let me quickly have a look at these structures, just so I know I'm not making stuff up off the top of my head. So diazepam.
That's how I always am. I'm always saying to myself,
they all look so similar that because of what they are, that I don't want to just think. So diazepam, then we've got midazolam, because I know one's got quite a nice midazolam. Spelling them is always fun. So yeah, midazolam's got a imidazole ring in the top, and the imidazole rings tend to be a lot more hydrophilic, so they like water. Lorazepam, similarly, it has an OH group, lorazepam, which is going to directly hydrogen bond onto water and make it less lipophilic. Midazolam's got the imidazole group, which again is capable of hydrogen bonding, whereas diazepam has neither of these, so it's going to be a lot more lipophilic. So it's going to sit in those fatty tissues for longer.
Yeah, and from a clinical aspect too, one of the things that, because we talked about earlier Diazepam Rectal Gel or the Diazepam nasal spray, and why would that be preferred over like lorazepam or midazolam? And that has to come from that we want that lipophilicity because it penetrates into the brain very, very well. So from an outpatient standpoint, you have your child suddenly fall down, they're going through a seizure, they're seizing, you'd want to use diazepam because it's more likely to penetrate into the brain versus in an inpatient setting where we can monitor the patient directly. We can pump them full of lorazepam and midazolam. That we would prefer these longer acting agents. The other thing too is that if your child is seizing and you administer diazepam, you're calling 911 as well, and you're getting them to the hospital where eventually they'll take care of them. But yeah,
I
great,
mean,
great questions.
over here in the UK, midazolam is carried by ambulances as well. So
I,
that would be.
I think it's the same over here too. Either midazolam or lorazepam, one of those. Very, very. I think paramedics carry it. I'm not sure. But as we continue along, our last section that we're going to talk about here is probably a really, really important part of talking about any drug, especially a controlled substance in the United States, which is tolerance, dependence, and withdrawal. And I think it's really important to understand what the mechanism of tolerance is. So tolerance specifically is when the effect of a drug decreases over time because of prolonged and sustained use. So someone taking their lorazepam every day for their anxiety, over time might see that the effect is going down, they're becoming more anxious over time, and the lorazepam may not be the best option going forward. There are generally three mechanisms of how that happens. The first is this receptor internalization, which is here on the right-hand side. And basically what that says is if benzodiazepine needs to find the door to the building in order to have an effect, it's almost like you're taking the front door off of your house. So lorazepam can't have an effect if you're getting rid of the door. And so over time, we might see that the receptors are being internalized inside of the cell, and that's why the drug is becoming less effective. This is probably one of the first tolerance effects that happens because receptor modification is actually a very, very common practice that happens among our cells and would probably start to present within a few weeks of using a benzodiazepine. That prolonged use eventually affects the genetic activation of the receptors, and we start to see decreased expression of the receptor on the surface of the cell. So what that means is that as you keep stimulating the cell, eventually it gets upset and says, okay, we're going to stop producing the receptor altogether. And so we see reduced expression. And then eventually, with so much receptor activation from the benzodiazepine, we start to change what the GABA receptor looks like by changing the subunits. And so you might see that they'll get that benzodiazepines bond between this gamma and the alpha subunit. So potentially our body just gets rid of that gamma subunit altogether and completely changes the site of action of where this drug is supposed to act. And so what we see is that over time, benzodiazepines can become much less and less effective. So what does that mean? Well, with a lot of people, if something becomes less effective, we tend to increase the dose of that drug. And when we start to increase the dose of benzodiazepines, we start to get into toxicities like oversedation, or eventually we can get into things like dependence. So dependence is the physiological process of being, quote unquote, addicted to a substance. And benzodiazepines can be both physically addictive and psychologically addictive. Psychologically, what we're looking at is this feedback between dopamine and reinforced behavior. So someone takes a benzodiazepine, they release dopamine in the brain, they feel really good. That's what the high is. And so they start to take more of it over time. And this is very, very common. We see it with many, many different kinds of drugs. Pretty much every kind of drug that is misused or abused goes through this psychological dependence. But we also see it in behavioral addictions as well, like gambling and shopping and eating, where that dopamine feedback reinforces the behavior. On top of that, we can see physical addiction, which is where we talk about withdrawal. And withdrawal is the body is so used to having a chemical inside of it that when it's removed, we start to have an adverse effect. And so what happens is that someone is taking their benzodiazepine, they stop taking it suddenly, and then they're going through withdrawal, they feel terrible, and so they have to take more. And they start to take more and more and more because they're avoiding with the withdrawal rather than maybe getting the high or maybe because they want to. So we see this a lot with opiates, is that someone, is only taking their opiate because they feel terrible without it. Same thing with nicotine. Nicotine can make someone feel anxious and jittery. And so continuously smoking can actually reinforce the behavior because you're avoiding the withdrawal. What we see down below is some great graphs that show that benzodiazepine use is increasing among younger people, which in the United States makes sense. It is a more party drug. You hear a lot about it in the music that's produced today. I think, Brandon, you said that benzos are generally an older population that misuse them.
Yes, in the UK, we had a heyday around, I don't know, 40, 50 years ago when benzos were first clinically used, and pretty much everyone was given benzos for insomnia. And now what we see is in our old people's homes, in our elderly population, practically everyone has a very, very high dependence on them. So our current clinical usage of benzodiazepines in outpatient settings, so outside of the hospital, is virtually non-existent. So yeah, it's almost the opposite of the US. We strictly control benzodiazepines over here, but as Gabe found out humorously in our chats, opiates are actually quite liberal over in the UK, and it's the complete opposite in the States.
Could not believe that. And someone in the chat also said that in Germany, young people started using benzos, and that they know many who have stopped using them as they got older. Benzodiazepine dependence, when we talk about physical dependence in withdrawal, I always like to talk about what is withdrawal. And when we look it up online and you look at the definition that Google will give you, they say that it's an unpleasant physical reaction that accompanies the cessation of taking an addictive substance. Okay, fair. When we think of withdrawal, we think of opiates, we think of alcohol, we think of all these different party drugs that are out there. But I take a lot of issue with this idea of addictive substance, because you don't need to be taking an addictive substance to have withdrawal. And so here we can see actually SSRIs, very, very, very common antidepressants. You can have withdrawal from your antidepressant. And so this can be flu-like symptoms. This can be really, really bad headaches and migraines, as well as dizziness and lightheadedness. And I've had a lot of people talk to me, I feel terrible, I don't know what's going on. I can't, I went to the doctor, they said that I didn't have the flu. I don't know what to do. And it just turns out that they haven't taken their antidepressant in a few days, which as soon as they do take it, they feel a lot better. And so this is something that I always have some big issues with, is that withdrawal doesn't have to be addictive. It can be literally anything. And you might be saying, okay, SSRIs, antidepressants, benzos, they all work in your head, right? So of course they're going to have a withdrawal. But here we actually see prednisone, which prednisone is a steroid that people can use for acne, psoriasis, many, many different issues. And what we see here is that this woman had been using topical prednisone for her acne and applying it every day as prescribed. And eventually her acne went away, she stopped taking it, and then she went through prednisone withdrawal. And that has nothing to do with the brain, and it's completely localized to the skin. So, this is a completely different situation that withdrawal doesn't necessarily just have to be a psychoactive substance. It can be literally anything, and it doesn't have to be addictive. So just some food for thought. When we talk about benzodiazepine withdrawal, it has a really interesting toxidrome where we see, some generalized adverse effects like, aches and pains, and nausea, maybe some depression from the adverse effects. But we also, and this is very common, is that we see the rebound of what it was supposed to be treating. So we take benzodiazepines for sleep, and when you don't have them, suddenly you have insomnia. And we take benzodiazepines for anxiety, and when you stop it, you produce lots of anxiety, even if you weren't necessarily taking it for that. Eventually, you can, with such severe withdrawal, you can go through seizures, and it can be a psychotic event. Generally, benzodiazepine withdrawal isn't necessarily, it itself isn't going to kill you, but it can be extremely unpleasant. When we look at the timeline of benzodiazepines, we see that it can last for 3, 4, 5 weeks, up to 6 months, maybe even a year. And so the dependence of that physical reinforcement of avoiding the withdrawal can be very, very intense, and can drive a lot of people to go back to using, just so that way they can stop dealing with all of these symptoms. One of the things that I like this Venn diagram on the bottom of the overlap of opiate withdrawal with benzodiazepine withdrawal is that a lot of them can overlap, and what we think of as an opiate withdrawal could actually be benzodiazepine, or even worse, a combination of both. So withdrawal is a major, major topic whenever you're talking about benzodiazepine, especially when we're talking about young populations misusing and abusing these medications. So with that being said, I want to pass it right over to Brandon again to talk about our last drug class.
So, as I'm sure Gabe has convinced you, the benzodiazepines do have very legitimate uses in clinical practice, and they're here to stay. However, for more, not necessarily minor, but outpatient uses, so our anxiety and our insomnia, we want to find something else. And we found something else, the Z drugs, as Gabe alluded to. Now, the idea from the medicinal chemistry standpoint was that these negative effects with the benzodiazepines would, with their common structure. So the benzodiazepines all have, down in this right hand molecule, the benzene ring on the left, the azepine ring on the right, and connected to the azepine ring, another aromatic ring. And all of the benzodiazepines share this structure. They just altered where it says, something different will be there, and those are your different drugs. And we thought that all of these bad effects were due to this common thing, this common structure. So medicinal chemists, we decided to try and start from scratch and make some completely different drugs. So we based it on, for some of them, these 3 skeletons, these 3 pharmacophores we see here, so the imidazopyridines, pyrazopyrimidines, and cyclopyrrolones. And so we have our Z drugs. However, we see that more or less the same things have happened. We have these Z drugs, so zaleplon, zolpidem, zopiclone, and unfortunately, we see more or less the same issues with them. We thought they were non-addictive, but it turns out they do still have addictive potential and dependence issues. If old people are taking them, they still suffer from falls a lot more often because they get ataxia. And so despite our efforts, we've seen that for insomnia, our best option is to try and avoid drugs altogether. We certainly in the UK, as someone who suffers from insomnia, my GP is very reluctant to give me any kind of medicine for it. Instead, I've been told, avoid caffeine after 12 o'clock. try not looking at computer screens or any screens before, an hour before bedtime. Don't do anything too intense, like don't do exercise in the evenings. It's all behavioral ideas of how we can train ourselves to sleep better rather than trying to fix the issue with a pill. So if we have a look at all of the history of these sedatives from a chemistry standpoint and from a toxicological standpoint, our initial drug, ethanol, so alcohol, it's not ideal. It's far from ideal. You've probably heard about yieldy operations where they just gave you a bottle of whiskey to try and knock yourself out, and then they got on with amputating yourself. Not the option I would go for. Then we found our barbiturates, which, as we've found, they do the job. However, the dosage between doing the job and outright killing you is rather narrow, so not ideal there. Our benzodiazepines have a far wider margin for error, and then specifically for insomnia, our Z drugs have an even wider therapeutic range. But at the end of the day, certainly for insomnia, I think the philosophy is that drugs aren't the answer, but certainly for sedation nowadays, benzodiazepines are pretty much king drugs here because they have this wide therapeutic range. It's easy to predict their pharmacology, their response in the body. So for doctors, they know roughly what dosage is going to have what effects. They know the dosage to stay away from where that's going to increase the toxicity. So yeah, that's the benzodiazepines for us.
At this point, I'd love to open it up to questions that people have. People watching the recording as well, there's going to be where this video will be posted on the subreddit. Feel free to just drop comments in there too. We would love to hear more about what kind of questions you have. We had a question from someone saying, shouldn't the benzodiazepines in the Z drugs have way lower surface area for a death panel than ethanol?
Yeah, I'd agree with that. That was
probably.
My drawing.
Yes. Yeah, definitely.
The barbiturate would probably be the lowest, but so barbiturates are infamous for their toxicity. But yes, if we're plotting dose of the drug as so directly comparable, then yes, you would definitely be right. This was more to display the therapeutic windows than absolute toxicity, though.
Who was it? I think it was Marilyn Monroe that overdosed on barbiturates and mixing it with alcohol. That was probably the combo that killed her. But do not mix these drugs with alcohol. Probably one of the worst combinations to do. Indeed.
I mean, Michael Jackson died from another sedative, so propofol, and I'm pretty sure he had benzos in his system. Yes, Marilyn Monroe, the toxic report said the cause of death was acute barbiturate poisoning. She had chloral hydrate in there as well, which is another yieldy sedative. But a very, very high amount of pentobarbital in her, so 15 mg%. So a lot.
Talk about the therapeutic index. The question about the alcohol here, when we talk about like therapeutic, we're looking at like the expected effect. So you can drink a lot of alcohol and have the expected effect of getting drunk. Before you could drink a lot of alcohol before you start to see like the breathing depression and the CNS depression. But there's no really way of comparing alcohol, like drunkenness, because I don't think it's ever been studied. One question we have is the pharmacophore common in the 3 drug classes, and how has it modulated to optimize activity?
So with those, I don't think there is a very common pharmacophore, simply because when we look at a pharmacophore, it's much more an idealized sort of model rather than a realistic depiction, if that makes sense. It's a useful tool for medicinal chemists to look at and say, if we have this structure and we keep all of these atoms and their connectivity identical and alter things off of it, in theory, the activity will remain and it will just modulate the how potent they are or the pharmacological effects. However, in practice, there's always exceptions to the rule. And when we look at, say, a protein, so our ion channel, what we look at is a static picture. And in fact, the crystal structures that we look at are crystals. They are very, very rigid. And we use X-ray diffraction to work out their structure on a molecular scale. However, in the body, they're in solution. They're actually very mobile, very flexible. So the binding of a drug into a receptor is far more, well, it's literally fluids. These atomic distances that we can measure under X-ray diffraction are actually constantly moving and constantly changing. So there's not a common theme here, and it's simply because biology is a lot more messy than we would like it to be. We can use these pharmacophores as a model. However, there's always going to be exceptions to the rule.
One of the things that we wrote a post about antidepressants, I think back in March, maybe early April, about how antihistamines, so drugs that you would use for allergies like Benadryl or cetirizine, were eventually modified to have more and more of an antidepressant effect. And that was through the development of basically just trial and error, saying, okay, we saw this effect, how can we make it better and how can we make it fit? And really drug development has just proceeded in that way, I imagine.
Yeah, I mean, a big thing in drug development at the minute is repurposing drugs. So you talk about the antihistamines, you probably have come across Cinnarizine being used for anti-nausea. It originally developed solely as an antihistamine, then we realized it has these antiemetic properties. Similarly, I believe not phenolzine, diphenhyd, no, not diphenhydramine. It's called promethazine. There we go. Is an antihistamine, I believe, but has antipsychotic properties. So, and these are just drugs that were actually marketed. There's plenty of drugs that passed phase 1 clinical trials that then failed in phase 2, but there's now resurgence amongst drug development research where we look at these drugs and see, actually, can they be used for something completely different? Because we know it's safe in humans, so why not try it for whatever other conditions and see if it does something? So that's something that's happening quite a lot. That's something I'm going to be doing in my own research, trying to make new antibiotics. I've just read a paper where the antihistamine clemistine was found to have antimicrobial properties. So it's, something you take for your hay fever, and as it goes, it would actually help with any infections you had. We didn't realize this until a few years ago.
The kind of almost the opposite to that as well is metformin, which is a very, very, very common diabetes medication nowadays. And it was originally discovered in the late 40s as an anti-influenza drug. And it was good at best. Like it barely did the job. And then eventually, about 20 years later, a French physician noticed that his patients who had influenza but were also taking metformin had better diabetes outcomes. And it was repurposed in the 60s as a diabetes drug, which is, again, like we discover a drug, we find that it's safe, and then we figure out it's actually much better in a different area. Metformin is probably the most prescribed diabetes drug nowadays as well. Everyone's on it. But
I think another humorous example of that, which goes to my own roots. So I studied my bachelor's degree in the University of Leeds, in the north of England, the UK. And while I was talking to my GP, my family doctor up there, he had worked on a clinical trial when he was a junior doctor for a heart medication, and they noted that the male patients were very reluctant to hand over any leftover medicine. And when they were asking about any side effects or other effects that they noticed, it prolongs the duration of their erections. So the pharmaceutical company involved scrapped it as a heart drug and remarketed it as the now infamous Viagra. So there you go. Sometimes even the patients can be responsible for drug repurposing.
That's a very good point. Yeah, it's probably one of the best examples of the different indications. Any other questions that we can tackle?
I mean, at this point, feel free to unmute yourselves rather than sit and try and type things. I think he's missing from the. He joined about halfway through. So you first, Gabe.
So I'm a PY4 pharmacy student. So just about to finish my pharmacy rotation, well, about to start and hopefully finish my rotations, and then maybe go into teaching, maybe go into hospitals. I don't know. I have to figure out what I'm doing. How about you, Brandon?
I'm a PhD student, so my background's medicinal chemistry. Specifically, I'm researching new antimicrobial drugs. So benzodiazepines is a bit out of my field, but the general medicinal chemistry is similar. So we're nice and complementary, me and Gabe. Gabe knows how to give the drugs to patients, and I know how to make them, and then we have sort of common crossover with things like SAR and pharmacology and ADME.
And a love for organic chemistry.
Indeed. You don't see that with clinicians.
He's at the end of his bachelor's in biochem. Yeah. Nice. Great field. I was going to go into biochemistry before I settled on pharmacy, but fantastic. All right. So I think we will wrap up here. Like I said, if you have questions, put them on the subreddit. There's a discussion post to throw them on there. The recording will probably go up later today. And thank you all for joining us today.
Thank you.